Also, this webinar has been approved for 1 contact hour of continuing nursing education credits. The webinar is eligible for award contact hours until December 31st, 2020. Next slide. iPrice is a CDC-funded injury prevention research center, and our goal is to reduce the top causes of injury and injury death in Georgia and the Southeast region through impactful research, education, and outreach. I encourage you all to please visit our website after the panel to stay updated on our current events and latest research findings. Next slide. Hannah Cooper, the iPrice Research Corps Director and the Rawlins Chair in Substance Use Disorders Research, will moderate today's panel, starting by introducing our panelists. Hannah?
Wonderful. Thank you so much, Ashley. You've been just a miracle worker when you've pulled this whole panel together, particularly virtually. So I want to thank you so much. It's my pleasure to moderate this discussion. I wish that we could all be together in person. Hopefully we will have that opportunity in the near future. I'm just delighted to introduce our 4 panelists today. Starting with Courtney Yarbrough. Courtney Yarbrough is an assistant professor at Emory University. Her research focuses on policies that are directed at substance use with a focus on opioid prescribing and also on access to treatment. Courtney is joined by Missy Owens. Missy Owens is the CEO and co-founder of the Davis Direction Foundation. That's a nonprofit organization that strives to fight addiction and fuel recovery. We're also joined by Neil Campbell. She is the executive director of the Georgia Council on Substance Abuse. Neil is a passionate advocate and is dedicated to influencing public policy through a recovery positive legislative agenda. And rounding out this remarkable panel, we have Dr. Elena Stack. Elena is an assistant professor at Emory University. She practices emergency medicine, medical toxicology, and addiction medicine at Grady Memorial Hospital here in Atlanta. I want to welcome all of you panelists. We're so delighted to have you. The panel will provide a 20-minute presentation on opioid overdose prevention topics. That will be followed by a moderated Q&A. In the last 15 minutes that we have together, we'll open the floor to audience questions. You'll see that your mics are muted, so the best way to get questions to us is to submit your questions and your comments in your chat box. And now we'll get started with the panel presentation. And Courtney, I believe, is going to start us off.
Thank you so much, Hannah. It's such an honor to be part of this panel, and I think the topic is really important. So I'm glad that we have so much participation in it. I'm going to just introduce the status of the opioid crisis in the United States first, and we can go ahead and show the next slide, please. And then talk about some local community level policies and actions that have been shown to positively affect opioid overdose. So these are the trends from the most recent published data from the CDC looking at opioid-related mortality and drug-related mortality. And there was a hopeful sign in 2018 because we saw about almost a 5% decrease in drug-related mortality between 2017 and 2018. And that was the first time we had seen a decrease in many, many, many years. About 2/3 of those deaths in 2018 were related to using an opioid. We saw decreases in deaths related to prescription opioids, small decreases in heroin, but counteracting both of those is that big continued uptick in the synthetic opioids, a 10% increase in mortality from synthetic opioids, which would include fentanyl. Next slide, please. So that was 2018, but of course there's a big lag in the data, and the CDC has been collecting provisional data along the way to try to keep us more up to date with what the status is of opioid use and mortality. And these latest numbers with the provisional counts from 2019 leading up all the way to January of 2020 show that that trend has reversed, sadly, and that we saw a 6.6% increase in mortality from 2018 to 2019. And so again, that's being led by fentanyl and synthetic opioids. Next slide, please. Of course, these data only go to January 2020, which is just on the cusp of when we entered into the current crisis related to COVID. And so now we have these dueling public health crises with COVID on the one hand and overdose on the other, and they're not unrelated to each other. Certainly the COVID pandemic is going to exacerbate the overdoses that we've seen in recent years. And, there are so many reasons for that. I think everybody here can attest to the stress that's been involved with the pandemic, people losing their jobs, economic insecurity, possibly oneself being sick or a loved one being sick, having to homeschool kids, et cetera, et cetera. I mean, it's an endless list of stressors. People might also have difficulty obtaining their medications for their opioid use disorder, or OUD, such as methadone or buprenorphine. And they might have difficulty attending meetings like AA or Narcotics Anonymous, or visiting their mental health providers. And so the CDC has surveyed adults during the pandemic, and in a survey from June 2019 or 2020, comparing that same period to 2019, we've seen big increases in mental health and substance use problems. So anxiety disorder was shown to be 3 times higher in 2020, depressive disorder was 4 times higher, and 13% of individuals surveyed reported having started or increasing substance use to cope with COVID stress. Next slide, please. Again, the data are always lagging, but an organization called ODMAP has seen a 62% increase among their participating counties in overdoses. So counties that have seen an increase in overdoses, 62% of counties have seen an increase. And a 17.6% increase in suspected overdose submissions after stay-at-home orders came into place. And in Georgia, that trend has also been borne out. There have been average weekly increases of 3% each week in overdose ED visits during the pandemic, and 6% weekly increases in opioid-involved overdose ED visits, along with 17% increase in fentanyl-involved overdose deaths between December and April compared to the previous year. Next slide, please. So we know that the COVID pandemic is affecting people in ways that are predictable related to overdoses. And so what are some of the things that we can do both because of COVID and also just because we need to be addressing overdoses? The next slide, please. One area that deserves attention is increasing access to the opioid rescue drug, naloxone, that of course resuscitates people after an overdose. I think one key aspect of having access to drugs like naloxone is understanding if pharmacies are actually carrying those or not. A recent study of Georgia pharmacies found that only 31% of the surveyed pharmacies had naloxone available for same-day purchase, and 65% of pharmacies did not carry naloxone. So it's worthwhile to be reaching out to pharmacies to make sure that people have access to this drug. Other considerations would be educating opioid users and their peers about how to use naloxone. For example, a lot of people don't realize that you can re-overdose after taking naloxone because the naloxone essentially wears out of your system faster than the opioids, allowing the opioids to kind of instigate a second overdose. So education is critical. And just ensuring that naloxone is widely available among healthcare workers, law enforcement, and community partners, along with opioid users and their loved ones, is really important. Next slide. Secondly, we have to increase access and utilization of medications for OUD. MOUD, or medications for OUD, are the gold standard of treatment for opioid use disorder. However, fewer than 20% of individuals with opioid use disorder receive any MOUD. And so there are a number of things communities can do. One is establish an opioid treatment program. In Georgia, 70% of counties have no opioid treatment program. These are essentially methadone clinics. Another thing to do is to engage actively with providers and encouraging them to get their DEAX waivers, allowing them to prescribe another drug that treats OUD, buprenorphine. In Georgia, there are also a great many counties that have no prescribers for buprenorphine. In fact, it's 45% of counties in Georgia have not a single prescriber. Suboxone, the brand of buprenorphine that's most widely utilized, recently became available as a generic. So that's good news. The price has dropped, and that should help encourage utilization. But one successful initiative that communities can take is to develop an academic detailing program. Detailing is when informed individuals visit healthcare providers and tell them the relevant information about certain kinds of treatments and diseases. And so reaching out actively to providers and encouraging them to prescribe these medications is really essential. And next slide. I realize my time is probably running out and we've got such an excellent panel. I'm going to wrap it up here, but I think the last word that I'd like to leave you with is networking between resources within the community. It's so essential to be able to help people who are in these moments of crisis and who are looking for help to be able to find the resources that they need. And that can be really daunting for some of the reasons that I just said, that oftentimes geographic access is very difficult, or that affordability might be a major concern for people. And so making different resources in the community aware of each other, so that when somebody visits the doctor and is going to be prescribed buprenorphine, that the doctor knows what pharmacy to send them to, that they can actually get it, or naloxone or things like that. And so, linking law enforcement with public health, with social service organizations, and with healthcare providers is really the key to building a network of support. So that's all I have for you today, but I'm looking forward to your questions. Thank you very much.
Missy, we are looking forward to your presentation.
Good afternoon, everyone. My name is Missy Owen, and I would just want to say thank you to Ashley, Hannah, Sharon, and the I Price at Emory group for inviting me to represent the Davis Direction Foundation in the zone here today. The DDF was established in 2014 after the fatal overdose of my son, Davis, who was 20 years old at the time. And in 2016, we opened the Zone, which was a recovery support organization to address 5 areas of the opioid crisis: education, prevention, advocacy, harm reduction, and recovery. We're located in Cobb County in the city limits of Marietta. And next slide, there we go. The Zone is where we focus on recovery. Our mission is to fight addiction and fuel recovery by providing a network of supportive services and friendly faces. We offer 34 meetings per week and approximately 40 services to help people regain, from helping people regain their identity to offering free chiropractic services every week. We have arts and crafts classes, computer lab, coffee shop, full-size commercial gym, pool tables, ping pong tables, video games, a full kitchen, and more. And we see quite a few people and have seen quite a few more faces coming in during COVID. Next slide, please. Due to the challenges we have seen with COVID, we have expanded our services to meet the increased need of people in our community. Many people in early recovery found themselves homeless, jobless, and hungry when we were ordered to shelter in place. Isolation and economic devastation were a disastrous combination for the recovery community, as you will see in the future slides. But some of the expanded services that we found that we needed to provide were things like 3 meals a day. We had people coming in who weren't allowed to stay home, weren't allowed to be couch surfing anymore because people were so afraid of COVID and this uncharted land that we were entering in the beginning. But we did provide virtual meetings, and because the county considered us to be first responders, we were allowed to keep our doors open because we were serving homeless people and feeding and meeting basic needs. So we joined a program that was addressing food insecurity by giving out food boxes, and we go every Thursday and we give out over 200 boxes every single week. We were giving out tarps, tents, and blow-up beds to address our homeless population. And then we were providing emergency peer-to-peer virtual support with Kennestone Hospital. for those who were presenting in the emergency departments with overdose situations. We led a series of 19 episodes of COVID strategies using our recovery coaches here at the Zone, addressing things like sober leisure, meditation and spirituality, facing fear with facts, time management, improving living space, just doing things that would help people get out of their headspace from being isolated and sheltering in place. We were giving clothing vouchers, transportation vouchers. So many things closed down, from people getting OR bonds when they were incarcerated. They weren't keeping them. They were coming straight out of jail, coming straight to the Zone, and with nothing but the clothes on their backs. So we were giving transportation cards. We were given gas cards from SA White Oil, one of our wonderful partners, who allowed us to be able to help people in those ways to get home, to get to people where they could have a place to stay. We were also Ubering people to essential services. We were giving hygiene bags. We were partnering with all of the nonprofits in Cobb who were meeting once a week to say who had what and collaborating so that we knew the services that everybody was providing. So we had plenty of services for our veterans, and then even had a Kennesaw police officer on his off time who had come up with a mobile laundromat coming to the Zone to help people wash their clothes and get them clean. So those were just some of the expanded services that we were giving to try to meet the challenges that we were experiencing. In March, when people closed down, we saw a very big dip in visits to the Zone, where we had been having over about 3,000 every month. Prior to March, we dropped down to about 1,609, and people were honestly trying to do what they had been asked by the governor to do. But then in April and May, we went back up to around normal. But then June, July, we just saw a very, very increased population coming in to visit. So our homeless population increased, and people were figuring out this COVID thing was around to stay, and they needed services, they needed support, and they needed resources. Next slide, where we see actually the national numbers were going up with alarming spikes in suspected overdoses nationally. March, April, and May, you can see those numbers where we were just soaring out of control with suspected overdose. And then next slide, the practices that we were doing that were making an impact. We were doing follow-up visits with Fire and Rescue. Cobb Fire and Rescue were going out and meeting with people who had had a recent overdose that they had responded to, and they were taking our recovery coaches, in particular our program director Justin Jackson, with them to talk to people peer-to-peer and actually give our information out, to provide them with a Narcan kit that we do give out to anybody who's out there with a high risk. And then another product that we give out all the time at the Zone is something called Dispose RX, which is something that gets medications out of the family medicine cabinet. It's like a little flower package you get with fresh flowers, and you pour it in a medicine bottle and shake it vigorously, and then you can throw the medicine out because the active ingredients have been deactivated and it's turned everything into a gel. So those were some of the things that we were doing preventatively. We're all trained in first aid, CPR and first aid here at the Zone, and are AHA certified. And then last slide is just kind of summing up what we talked about, the challenges and the solutions, and just the things that we provide. We're happy to be here for the community of recovery here in Cobb. This has been a calling, and God has blessed us richly with the people that we need to have here and the community to support the services that we offer. So if you need to talk further to us, our contact slide is last. And again, thank you all for this opportunity to present.
Excellent. Thank you so much, Missy. Neil?
Hi, good afternoon. Thanks so much for having me. My name is Neil Campbell. I'm the Executive Director of the Georgia Council on Substance Abuse. I'm also a woman in long-term recovery, and what that means for me is that it has been 30 years since I've had my last drink or illegal drug, and I speak out about my recovery because I want everyone to have the opportunities that I've had to get and to stay well. And because of my recovery, I get to be the executive director of this amazing organization called the Georgia Council on Substance Abuse. Next slide, please. And our mission is to increase the impact of recovery in our communities through education, advocacy, training, and peer recovery support services. Next slide. And who we are for over 20 years, actually we have our 20th anniversary this year. We've been a voice of recovery in Georgia. We provide, as I said, advocacy, training, education, and peer recovery support services. We ensure that the peer voice, the recovering person's voice, is heard. We believe in nothing about us without us. And we've gone from 1 employee in 2008 when I became the executive director to we have close to 35. We have 34 actually right now, all people with lived recovery experience. We've seen 1 peer-run recovery community organization to 31 now in the state. So you can think of us as the Home Depot of recovery. You can do it and we can help. Next slide. So just want to talk a minute about advocacy, the cornerstone, about education. The cornerstone of what we do is to build and sustain cultures of recovery. There is a culture of recovery. There is such a thing as recovery focus and recovery orientation. I'll talk about that in a little bit, but these are some of the trainings that we offer. It is also National Recovery Month in September, and we had our big kickoff yesterday. We had a congresswoman and the Secretary of State from Georgia show up and honor those of us who are either seeking or in recovery. And we also do Addiction Recovery Awareness Day at the state capitol, where last year we had over 1,200 people talking about how they got recovery and stay in recovery. Next slide. In terms of advocacy, we do a lot of policy development. We teach folks how to speak with their legislators in a recovery positive voice. We have a stigma reduction campaign that we've done, and we work on the national and local level. Next slide. You will see this. This is one of the things we advocated for, had a law signed, recovery is real. You will see this license plate go on sale in this next year. We want people to realize that there's folks like me, there's tens of thousands of us in this state that are in recovery and that we want to help. Next slide. The other thing that we've done is is our training. The cornerstone of that is our CARES Academy. And we have, I was looking at the list of participants. There's a bunch of CARES, Certified Addiction Recovery Empowerment Specialists. These are trained recovery coaches. They're on the call right now, and they're amazing people working in just a variety of behavioral health and healthcare settings. Next slide. And one of the things we have done is develop recovery community organizations across the state. You can keep clicking on that. We organize focused recovery conversations around the state. We have local recovery symposiums. Just had our first virtual recovery symposium in Cherokee County last weekend. And what we try to do is foster collaborative relationships and turn into the hubs of recovery in all of these communities. Next slide. Here's just a list of the folks that are running peer-run recovery supports. So this is where you don't need a diagnosis. You can walk into these organizations and look for jobs. You can get the kind of social activities and things that really help people in recovery. And this is the impact that it's had. Next one. We have had, so this is some data provided. We work in partnership with the Department of Behavioral Health, and just 16 of these recovery community organizations have touched this many lives since they came on board in September of 2018. So we had close to 4,000 unduplicated services a month and 14,000 peer services a month in total. So the actual peer touches. Next slide. And at the council, we do services ourselves. We are in 3 rural hospitals and emergency departments. We also are in 2 neonatal intensive care units. And when I say we, I mean recovery coaches. We do telephone recovery support. We have a warm line where we have a recovery coach on duty from 8:30 in the morning until 11 at night. We have seen a 60% increase in those calls since COVID came. And we do also virtual all recovery meetings. Next slide. So we have had in our Northeast Georgia community connections within our emergency departments, we have seen 4,900 individuals in 3 rural hospitals, and we've done close to 6,000 follow-ups with them. We also do naloxone distribution, and we connect our peers to community supports. Next slide. This is fast. And in our neonatal intensive care unit, what I'd like you to see here is that we have helped decrease the length of stay in the NICU from 19 days to 15 days. And that has been remarkable to see. We've actually gone upstream, and now we work out of the OBGYN clinics to start forming relationships with moms before they deliver. Next slide. And if we have 2 all recovery meetings per day. So if you are interested in calling our being part of our all recovery meetings, you can go on Facebook. We also have on Tuesdays Spanish speaking meetings, two of those on Tuesdays, LGBTQ meetings on Thursdays at noon, and then again at 10 o'clock and 2 o'clock, 10 o'clock and 7 o'clock every day. Next one. And you can click through that as well. All of this is going to be on our social media. We are social media beasts. We're on Facebook, Instagram, and Twitter. Please connect with us. I am so grateful to be here. We are here as the recovery community, supporting the recovery community. Thank you.
All right, well, I will just jump right in. I am just in awe. It has been so wonderful just to hear about all the incredible and absolutely inspiring work that everyone has been doing. As Hannah mentioned earlier, my name is Elena Stack. I'm one of the faculty at Emory, but my primary clinical site is at Grady, where I work in the emergency department. So you kind of see everything that's happening on the front lines. And I also head up our medication-assisted treatment clinic at Grady, which utilizes buprenorphine products and extended release naltrexone, so known by the brand name Vivitrol. And just really happy to be here today. And because we have limited time, I'm going to focus pretty narrowly on one of the projects that we've been able to implement at Grady over the past year, and that'll be our ED naloxone distribution program. So on the next slide, I just wanted to provide, and you're going to have to kind of click through for each of these animations, just some background on what's been going on in the world of emergency medicine as it relates to the opioid epidemic and the role that emergency providers and emergency departments play. As Dr. Yarborough mentioned earlier, you know, there's been a lack of access or some difficulties in accessing medication and treatment providers, either through the closing or limited services provided by OTPs and individual buprenorphine prescribers. And so the ED has become even more a critical point of healthcare access than we've seen in prior years. And over the years, what we've seen is a number of different studies and initiatives aimed at primary prevention, so reducing the amount of opioids that are coming out of the emergency department, and then trying to kind of shift the culture and focus from just managing an acute overdose and getting someone out the door to initiating treatment in the emergency department. And that includes not only initiating medications for opioid use disorder, as D'Onofrio and her group showed in 2015, but implementing a more robust warm handoff system, so getting people linked directly to care. As Neil and Missy spoke about, getting peers in the emergency department. And then again, what I mentioned I'm going to focus on today is this overdose education and naloxone distribution. Before we go to the next slide, what I want to highlight here is a study by Samuels and their group, which came out last year, which is just a really nice summary of some of the implementations that have occurred in the emergency department over the past several years and a way to evaluate the success of these programs. And so that paper in particular, we will make sure is available to everyone who's participating. So you can just click through that next slide. So what we know about opioid overdose education and naloxone distribution is that in a variety of settings, implementing an OEND program is going to reduce overdose deaths, and that it's something that we can do in a variety of ways. So it doesn't just have to be giving naloxone in the emergency department, but this has been shown to reduce deaths in community-based programs, in correctional facilities, and then in large academic health systems, as well as in community practices. The other really interesting thing about it is that not only does this improve the knowledge of overdose treatment options and overdose prevention for the patients or their family members who are seeking these services, it really changes the knowledge and practice of the providers who are giving these services. And so a lot of the time, just getting the culture shift is something that's really difficult to do. And we've seen that with OEND programs, this is one of the ways that you can shift to the provider culture from, as I mentioned earlier, kind of the old school treat and street sort of approach to a more holistic, recovery-oriented goal. So next slide. So what we are able to do at Grady, the Department of Behavioral Health granted us some funding last year to be able to provide intranasal naloxone to anyone who comes in our emergency department who is either post an acute overdose or who's at high risk for an overdose. And we elected to go with the nasal spray because in end user studies, it's definitely the most user-friendly of the bunch. The injectable forms of naloxone are much less expensive, but understandably, there's a lot of wariness in bystanders in using a needle to administer a medication to someone. So each person who receives a naloxone kit, that's 2 doses of the 4 milligrams of the naloxone nasal spray. And we found that this is a really important service to offer to people because although you can A, prescribe naloxone, and B, in Georgia, it's available via the standing order, so you don't need a prescription to fill it, it's still quite expensive. Without insurance, these 2 doses run about $140. And even with insurance, the copay can be as high as $50 for these 2 doses of naloxone. So for many of our patients, that is prohibitively expensive. And so in being able to offer this free of cost at a moment of salience to people in the emergency department, I think has been a huge success. If anyone has questions about how we started this program, any of the challenges that we had to overcome, some of the logistical barriers, I would be happy to talk about that either later in the open question session or offline at another time. My email is there. Feel free to reach out. So thank you very much.
That's wonderful. I want to thank all of our amazing panelists today for their really informative and rich and inspiring presentations. I have a few follow-up questions that I wanted to ask the panelists, and then we'll open it up to the audience Q&A. And just as a reminder to the audience, your mics are silenced, but you can pose questions in the chat box. So my first question is for Neil, and the question is, how important is it, do you think, to use non-stigmatizing language when you're talking about an opioid overdose?
I think when talking about any type of substance use disorder, it's extremely important to use non-stigmatizing language and recovery-focused language. And what I mean by that is that language both creates and reflects culture, right? And so to develop a recovery culture, a recovery positive culture, you have to use appropriate language. And what we consider that to be is person first. So when I introduced myself, you heard me say I'm a person in long-term recovery. I'm a person first. I didn't say my name is Neil and I'm an alcoholic or I'm an addict. I do that in certain mutual support groups, but I don't do that in the general public because I want people to see me as someone who has overcome something, and that in my case has been addiction. So I think using that language is extremely important. We don't say things like once an addict, always an addict. Where did that come from? That came from, nonsense. It's just not true. We don't use that language. We don't say things like you have to hit bottom, because we know, especially with opiate use, if you tell someone they have to hit bottom, a lot of times that means they're not going to make it back. We don't say relapse is part of it. So I know some of this stuff has just become part of the lexicon in our language over the last 40, 50 years, and it's just not true. Relapse was never part of my recovery, and it's not something we want to set up as an expectation. So I think language is really, really important. And to use things like recovery and recovery community, service, because people in recovery have a great tradition of giving back. I think just lifting up all the strengths of people in recovery is really important.
Thank you so much, Neil. And I was so excited to see the license plate. That was great.
We'll have information soon.
Excellent. The next question is from Missy. And Missy, how does the Davis Direction Foundation serve as a catalyst to address a paradigm shift that's necessary, I think, to inspire change in the ways that we think about the opioid epidemic?
Well, the zone is what we consider to be our catalyst, Hannah, and the way that we talk about the paradigm shift is, many times, especially in early recovery, people come in and they consider themselves to be burdens to their families, to their communities, and we teach them to be the blessing that they are to their community through offering so many different types of ways for them to shine at the zone, like through arts and crafts, through music, through computer skills, or helping others. And I'll never forget, we had a Christmas open house, one of the first years that we were open, and we put recovery art out on display as a fundraiser. And one of the people that participated in the recovery art was this young man who had come in, and he was a very good artist, and he painted shutters. He sold 10 shutters and raised $1,000 for the zone. But he was so proud, and he learned how he could give back and how he could be a blessing to others and to our community. And then when people would come in to visit the zone or look at the art for the fundraiser, they would see our wall, and we have a wall of those we've loved and lost. And one of the things that they see when they see there, they see people that are just like you and I. They see people that are in military uniforms. They see mothers holding babies. They see families with fathers, and they come to the realization that paradigm shift is, wow, that could just as easily be me on that wall. And then the more they come and the more they see and the more they are around those people, as they consider them to be, sometimes when they haven't had the education or become properly introduced to the community of recovery, then they have that whole paradigm shift that just shows them that this is not any different than any people that I see anywhere else. So the zone does all that for people and is a real icon in the community.
Well, thank you so much, Missy. That was a wonderful answer. The third question is for Elena. In your opinion, what is the role of emergency room practitioners in preventing harmful opioid use?
So, as emergency providers, I mentioned earlier that the emergency department, even before COVID, even before the opioid epidemic, the general trend has been that the emergency department the emergency department is becoming an increasingly important access point for all healthcare, not just broken bones, car accidents, acute overdoses. And so, as emergency providers, when we are taking care of someone in the ED who may not even be there for an opioid-related complaint or something that is suggestive of OUD, we have this really unique opportunity and a responsibility to address kind of the entire spectrum, from preventing opioid use, or aberrant opioid use, to taking care of people once they're kind of in the throes of an opioid use disorder. And so on the prevention side of things, I know one of the things that was really beneficial was the implementation of universal PDMP use among emergency department prescribers. So the Prescription Drug Monitoring Program, which is a database that is maintained by the Department of Public Health. And when someone fills a prescription for a controlled substance, that information is uploaded into the PDMP database, and practitioners can then query that database for a particular patient and see what their pattern of controlled substance use has been. It's been a really useful tool because it helps limit the amount of opioids that we are getting into the community. but it also provides a touch point for us to talk to people who are maybe transitioning from initial use into harmful use about what's going on, what the factors are that are involved in this transition, and start to introduce people to some of the resources and the services that are available. So, you know, the prescription thing is one part of it, and kind of that primary prevention side of things. And then, as I mentioned earlier, getting kind of into that secondary, tertiary type of prevention where we start talking about naloxone distribution, harm reduction. So I counsel many of my patients about ways to stay safe, particularly in the era of fentanyl and fentanyl contamination across the drug supply. And then, you know, just hooking people up with resources. And again, really trying to push forth that culture change. Historically, the medical community has not been very welcoming to people with substance use disorders. And so trying to impart to people that the ER is a safe place, that there are people who understand and want to help. And so, you know, kind of all of those things together, you know, puts us in a really, like I said earlier, unique position to kind of help across the entire spectrum.
Lovely. Thank you so much, Elena. I really appreciated that answer. I think the next question is for Courtney. And the question is, do you believe that there are better long-term outcomes from medications for opioid use disorder as opposed to abstinence-based programs? What's your perspective on that?
So this is such a good question, because I think that there's a lot of confusion out there about whether, you know, one is better than the other. But when you look in the literature and at the evidence, there really isn't any confusion about it. Medications for opioid use disorder are the gold standard for treatment. It can be part of many different resources that people draw upon to help them to maintain recovery. But individuals who use opioid agonist therapy, for example, that would be methadone or buprenorphine, have at least twice or are at least twice as likely to have negative urine screens for opioids when they're taking it. And they have 2 to 3 times lower mortality when they're on opioid agonist therapy. So there are really clear signs that these drugs can help people in substantial ways. The question referred to long-term outcomes. There was a study that followed up with people who had taken opioid agonist therapy after 42 months, and a very large percent of those people had maintained their abstinence, even though some had tapered off the opioid agonist therapy. So it really does help people in long-term recovery. And then there are some other, you know, benefits of it as well. We have seen evidence that there are lower rates of hepatitis C transmission when people are on agonist therapy. So, you know, one of the things, of all the things that have been so tragic about the opioid crisis, I mean, we're very lucky that we have these drugs. Opioid use disorder is the only substance use disorder apart from alcohol use disorder that has FDA-approved drugs that can treat it. And we have naloxone as a rescue drug. So utilizing these tools that we have is essential. And that's going to entail reducing stigma, not just among patients, but providers, and the treatment community. Oftentimes you hear stories of people, you know, feeling unwelcome in 12-step programs, for example, because they are taking medications. And then, as I mentioned before, 2 other major barriers to people having access to these medications is geographic availability, especially in rural areas, and also affordability. And so those are other directions that we really need to address these access issues.
That's lovely. Thank you, Courtney. So this last question is for the whole panel. And the question is, how has COVID affected the opioid crisis? In your opinion?
I think we're still learning a lot about, you know, what, how it is affecting people, except that we have seen just today a lot of alarming evidence showing that people are, you know, starting to use substances again if they had problems in the past. And that can be really dangerous because if somebody has been abstinent for a long period of time, they are more likely, they've lost their tolerance more likely to overdose when they start taking again. So that can be a really dangerous time. And of course, all of these barriers that are there in normal times are just exacerbated because of stay-at-home orders and not being able to get appointments with providers and things like that. So we're seeing these things play out, but I think it's clear that this is really going to be a setback for all the work that's been done related to overdose prevention.
Yeah, I totally agree with that, Courtney, and I'm really scared. I'm worried, so worried about young people, about high schoolers. I think that they're, you know, if you're not laying eyes on high school kids a lot, that sometimes they can revert to really unhealthy behaviors if we're not there to kind of lift them up. So I'm worried about that population. And I think I mentioned in my presentation, we've seen a 60% increase in our calls to our peer support warm line since March. And then we started these virtual all recovery meetings. And, you know, some people find it, not everybody is an extrovert like me and likes to be out and about. So we have some people who would never walk into a 12-step meeting signing on to our virtual all recovery meetings because they just feel more comfortable in their home. They don't have to leave their home. So I think that has been actually a positive that's come out of this, that people have found virtual ways to connect. But I think I think COVID is going to have just a lingering effect on those of us who are in recovery or seeking recovery going forward. I just don't think we have any idea of how impactful it's going to be going forward. But I'm hoping that people are realizing that it's about the connections and they can reach out. There's other ways to reach out. So I think we'll see.
Thank you so much. That was a very rich discussion. And now we're actually going to turn it over to the audience Q&A. And for that, I think that Ashley is going to be reading out some of the questions that have been posed by the audience in the chat box.
Sure. So we have a couple of questions for Elena, and I'll try my best to pull them all together. The question is about record keeping and better responses from emergency departments, and also what it means to do or to have a warm handoff. So can you talk a little bit about that,
Yeah,
Elena?
sure. So I will tackle the question about record keeping and the issue of, you know, pain management in the emergency department for people who are in recovery and requesting not to have opioids. I think I don't have a clear answer for this. So this is all my opinion and kind of my guess as to what's going on. But the first is, as far as why don't we keep good records of who's in recovery and who does not want opioids? I think it's because there's not a good place in the medical record to do it. So in an electronic medical record system, there are very clear data entry points, and they show up in the chart for things like allergies, medications, other medical history, and we don't do a good job of documenting. There's no ICD-10 diagnosis that comes up super clearly for person in long-term recovery, do not give opioids. And so that is something that I think needs to be tackled on a systemic level. You know, obviously we all pay attention to what a patient's allergies are, but more to the point on an individual systems level. So like our hospital system would have to build that into our electronic medical record. Otherwise, there's just not there's not a preset place in the chart for providers to enter that information and then be able to look it up. So that's issue number one. Issue number two has to do with some of the culture and paradigm shifts that we talked about earlier. You know, when I was in medical school, which, you know, was not that long ago in the grand scheme of things, we were taught that opioids were not dangerous medications, that if you had true pain and you were given opioids, you could not end up having an opioid use disorder. And like I said, that was not that long ago that was taught. And so that culture still is in the process of changing. It's such a slow process. And so I think people don't necessarily give the request from a patient to not use opioids its due respect. just because they weren't taught that that's something we really need to pay attention to and really need to honor. The last thing that I'm going to say is on that is we always jump to opioids because they are the most effective pain control agents we have. And so our options for pain management without opioids can be quite limited, especially for people who have really gnarly injuries like broken bones or, spine fractures, things like that. So that's that. The second question was, I forgot.
That's okay. I think you did a good job covering the topics, Elena. We have a couple more questions here. One person has asked that made the comment that we really need recovery community organizations in Glenn County. She says that she's benefited so much from peers empowering peers. So how does a community get that type of organization or service in their area?
Yeah, so we work with the Department of Behavioral Health and Developmental Disabilities to work with local communities. So I will put an email address, he'll probably kill me, in the chat box of Jean Conroy, Brian Kite, and Emily Riblet. They're three of our staff that work on RCO development. So you can reach out to them and they can get your process started.
Okay, great. There's also a question about the panelists' thoughts on the role of a collegiate recovery community, particularly when we are navigating COVID-19. What are some of the panelists' thoughts on that?
Could you repeat that real quickly? I was responding to something else in the chat box, something about collegiate communities of recovery, so through higher education?
Yes.
I think any way that people can find to come together and, have a reason to join together in recovery efforts is great. That's an age group that would benefit a great deal from those kinds of services. And so absolutely, that's a venue where it would be really beneficial to have support networks and access to medications and things like that.
Yeah, Kennesaw State University has a great collegiate recovery center. University of Georgia, I think Georgia Tech started one. They're all over and they're amazing programs. I went to one of the original ones in Lubbock, Texas, and it was phenomenal. I mean, these young people were just out there talking about their recovery, talking about how they get support. I went to a meeting there that had over 200 young people. So I think they can be really powerful places. I know when I was in college that my college campus was a very abstinence hostile place and I had no one to go to for support. So I think they can be amazing programs.
Excellent. We also have a question about access to Narcan and how organization can get access to Narcan.
We give out Narcan at the zone, Ashley, and all you have to do is come by and we train you very quickly in how to use it. And we also give out the Dispose RX as well. One of the main things that we need to do is get all the medication that leads to the opioid addiction out of the medicine cabinets. And so, if we could do that, we could dismiss so much of the heroin addiction that comes later just by getting the medication out of the family medicine cabinets. But the zone gives to sober living houses, recovery residences, we give to law enforcement, and we've done trainings all over the Atlanta area. So we're here for that if anybody needs us.
Yeah, and there's an organization called Georgia Overdose Prevention, which does amazing outreach and training and naloxone distribution all over the state. So if you, oh cool, someone just put it in the chat box. So I was going to say, if you just Google Georgia Overdose Prevention, but that's a direct link to their website. So
excellent. And Missy, we will, if you could share your contact information, we'll make sure that gets out to everyone as well. So that's all the time that we have for our questions. Do we have any final comments from our panelists or our moderator?
Just want to say thank you to everyone for all the work that you're doing. It's great to see everyone's face without masks. Hopefully we can get together in person again soon.
That's right. And, thank you to the panelists. This was such a wonderful and rich discussion on a topic that's of vital importance to all of us. You can see that Ashley is putting up a couple of questions on your screen. If you could possibly respond to both of those poll questions, that would be lovely. Your feedback will help us, determine the contents of future webinars. I'll give you a moment to do that. Ashley, can you see the responses coming in? Do you want to?
Yes.
Okay. Tell me when you think we've hit a good point, and I'll continue the wrap up.
I think we're right about half, a little over half, so we're doing good. We can wrap up now.
Okay, lovely. So I've been just delighted to be your moderator today. If you want further information about iPrice, that's the Injury Prevention Research Center at Emory, you can visit our website. You can also contact us via email. You've been hearing from Ashley about this presentation, and so you can go ahead and contact her as well. I want to extend my warmest thanks to the panelists and also to everyone who joined us today. We very much look forward to seeing you again soon. Take care.
Thank you.
Thank you. Bye-bye.
Everybody, have a great day.